Good morning, good afternoon, good evening, everyone. And today we are going to do the question reviews for the feeding and eating disorders. This is simply us checking our understanding because I believe that the feeding and eating disorders DSM-5 video has already gone out already. So this is us checking our understanding, getting to get familiarized with how some of these words, terms, phrases, or these core symptoms appear in our mock exams that we might be taking, as well as the real MFT national exam. But also keep in mind, this is not just for the exam. It's also going to help you work with your clients, your couples, your families, whatever the case may be, as you are practicing in the field of marriage and family therapy. So let's get started with the first question. And like always, feel free to pause this video, find the best answer before I find the best answer. A 17-year-old female is brought to therapy by her parents due to recent weight loss, refusal to eat meals with the family, and excessive exercising. She expresses intense fear of gaining weight and states, "I just want to be healthy." Her BMI is significantly below normal. Which diagnosis is most consistent with her symptoms? Like always, we are treating this as if we are taking the actual MFT exam, where we're going to go back, look at this vignette, and find out what words, terms, phrases, core symptoms is going to lead us to our best answer. So if you take a look, she has recent weight loss. She has expressed an intense fear of gaining weight. She's also been excessively exercising, and her BMI is significantly below normal. So out of the four, which one of these is our best answers? A says avoidant restrictive food intake disorder. So if you've already watched the video, you would know that with avoidant restrictive food intake disorder, a person does not have a fear of gaining weight or becoming fat. Yes, they also have sometimes significant weight loss, but it does not come with the fear of gaining weight and intense fear of becoming fat. So that means that A is out. B says bulimia nervosa. There is something that must come with the diagnosis for bulimia nervosa that is not mentioned in this vignette. Leave a comment, send me a message, and let me know why B is not the best answer of the four. C says anorexia nervosa. I like that, but take a look at D. D is also says body dysmorphic disorder. With body dysmorphic disorder, a person has this perceived flaw that they are like really entangled with, that they feel like something is wrong with them, or they may feel like they look a certain way, but to other people they don't. That means it's going to come with what? Constant validation, reassurance, and mirror checking. That's not mentioned here, so D is not the best answer. But if you go back and take a look at C, anorexia nervosa, restricting type, that is your best answer. Significantly below normal BMI, fear of gaining weight, saying she just wants to be healthy, and she's also been excessively exercising. Those are some of your core features of anorexia nervosa. All right. A couple seeks therapy because their 10-year-old son refuses to eat most foods and has begun losing weight. The parents argue frequently about how to manage his eating behaviors. Which intervention is most appropriate in the initial phase of treatment? Now, here's the thing about this question. Take a look back at, because it's asking us about the most appropriate intervention that you're going to do in the initial phase. Not a goal. They're not asking for a diagnosis. This is an intervention they're asking for. But if we take a look at the vignette, he's refusing to eat most foods and he's begun to lose weight. So I think that this is probably your restrictive avoidant disorder that they're discussing. But let's take a look at the answer responses. A says refer the child to a pediatrician for a full medical evaluation. I like the sound of that. But let's take a look at B. B says teach the parents nutritional techniques and food exposure methods. My issue with B is that it's ignoring that he's begun to lose weight. And we want to make sure that he's okay, right? C says explore how family conflict may reinforce the child's symptoms. C is also ignoring that the kid has begun to lose weight. And we want to make sure, again, that he's okay. Always going to be safety first. D says begin cognitive restructuring with the child. Again, D is ignoring the fact he's losing weight. We need to make sure that he's okay, leading us to A being the best answer. Refer the child to a pediatrician for a full medical evaluation. That is the first intervention that you are going to do. When you are presented with some things in the vignette that is saying that, hey, I need to keep this client safe, so you need to refer them for a full medical evaluation if any if there are any physical symptoms that are being presented. We are not doctors. That's outside of our scope of practice. So we always, always, always are going to have to refer to get them the best help that they need. Now, a 22-year-old college student presents with episodes of consuming large quantities of food followed by vomiting. She maintains a normal BMI and is ashamed of her behavior. She denies any restrictions between episodes. What is the most likely diagnosis? Again, let's go back to the vignette. Take a look at it. She's consuming large quantities of food, and she's following that up with vomiting, and she has a normal BMI. Those are your specifiers that's sticking out to you that's going to lead you to your best answer. A says bulimia nervosa. Okay, I like the sound of that, but let's take a look at them. B says binge eating disorder. The issue with B is with binge eating disorder, there is no vomiting that's happening. They are only eating and consuming large amounts of food within a 2-hour period. And then I believe so that they can, feel shamed, feel guilty about what they're doing. But binge eating disorder does not come with the vomiting. C says anorexia nervosa, binge purge type. The answer for C, my issue is that she has a normal BMI. Those who are diagnosed with anorexia nervosa sometimes does not have a normal BMI. Their BMI is significantly low, meaning C is not the best answer. D says purging disorder. I don't even know if that's a real diagnosis, so we're getting rid of it because binge eating disorder it's about towing the lines of the same thing. So D is not your best answer. But if you go back and you take a look at A, bulimia nervosa, she's consuming a large quantities of food and then she's vomiting. She is engaging in some of those the compensatory behaviors, which is causing her to also feel ashamed and may feel guilty after she's doing it. She denies any restriction between episodes, which means that it cannot be any of the others, right? It's going to be A is the best answer, bulimia nervosa. I hope that makes sense to each and every one of you for how you are going to navigate some of these questions when it's like bulimia nervosa and anorexia nervosa. With bulimia nervosa, sometimes you are going to have a normal BMI or your BMI might be a little high with bulimia nervosa. But with anorexia nervosa, your BMI may not be normal. It might be significantly lower than what it should be. That's how you spot the differences between bulimia nervosa and anorexia nervosa if and when you do see them in your mock exams or when you are taking the real MFT national exam. A 7-year-old child is brought to therapy after the school nurse discovered she has been eating chalk and paper regularly for the past 2 months. The parents initially believed it was a phase, but the behavior has continued. The child is otherwise developing normally and does not have an intellectual disability. What should the therapist do first? Now, before we take a look at some of the answer responses, we know that in the vignette, they are describing which diagnosis. It's pica. With pica, you are going to be doing what? Eating some of those non foods. I think that's how you can say it. Something that's not food. It has no nutritional value, and it's not going to be appropriate for the age of that child, right? So if you were to say like, oh, maybe a baby or maybe a 1-year-old, 2-year-olds, when they go outside, they put things in their mouths or they're putting things in their mouths. That's appropriate for their age. But a 7-year-old eating chalk, it's disappropriate for their age. And we know that the diagnosis that they are speaking about in this vignette is pica. But let's take a look at the answer responses. A says diagnose the child with pica. Okay, I like how that sounds, but let's take a look at the other ones first. B says refer the child for a medical evaluation. Okay, I like how that one sounds too. C says explore family dynamics around meals and parenting style. Okay, my issue with C is that this is a first question. And with first questions, typically it's what you're going to do because something needs to happen immediately here, and it can't be something that's going to be maybe too clinical in nature, especially when you have a child eating chalk for the past 2 months. I can't sit here and explore family dynamics with you when you just told me your 7-year-old has been eating chalk for 2 months. I got to make sure that he's okay. Okay? D says begin psychoeducation with the parents about nutrition. Again, Your child has been eating chalk for 2 months. I need to make sure he's okay. So take a look back at A and B. A is diagnose the child with pica. We know that the diagnosis is pica from reading it in the vignette, but A is also ignoring that the child has been eating chalk for 2 months, and I have to make sure that the child is not getting sick from it. He's developing normally, that's fine, but internally and physically, how is he feeling? He's been eating chalk for 2 months. You can't eat chalk for 2 months and tell me that something's not gonna be going wrong with you. B says refer the child for a medical evaluation. That is the first thing that you need to do. Even though she's saying, oh, the child is developing normally or whatever, it doesn't say that they've taken the child to the doctor already. So we need to be saying, hey, I think you need to get him checked out medically just to make sure that he's okay. Right? Which of the following clients would not meet the diagnostic criteria for pica according to the DSM-5? So for these types of questions, if it's kind of hard to understand them, I know the questions that say like, oh, accept this one or would not, you're just going to reframe it in a way that's going to help you understand it. Which of these clients presented in these questions does not meet the criteria for pica? There are criterias in these answer responses that do, but we need the one that does not meet the criteria, okay? A 16-month-old child who puts dirt in their mouth while playing outside. Okay, the 16-month-old is about what? That's a year and something, right? Remember we said, right? If it's appropriate for the age, it's nothing that we can do about it because, right, they don't know any better. But like a 7-year-old, 6-year-old, 8-year-olds, they shouldn't be eating, things that are like chalk for 2 months, like the last question. Let's take a look at B. B says a 6-year-old with autism spectrum disorder who eats small rocks regularly. Okay, now this is the 6-year-old, right? They're 6 years old. They know they should know better, right? 6 years old in autism, like the parents is like, well, they haven't stopped doing or whatever. 6-year-olds, it has to be diagnosed with pica, it has to be disappropriate for their age, right? So the question is asking which would not meet. 6 meets the criteria because it's disappropriate for their age. B meets the criteria. C says a 14-year-old who has been chewing and swallowing paper for 3 months. C meets the criteria. D says a 30-year-old man with iron deficient anemia who compulsively eats ice. I don't see anything wrong with that, but okay. D meets the criteria because they're compulsively eating ice. It's like non-food, so you still have to consider it being ice being like non-food. It has no nutritional value. But if you take a look at A, a 16-month-old child who puts dirt in their mouth while playing outside, they would not meet the criteria for pica because that's appropriate for their age. A 16-month-old, it's okay. They don't know any better. You go out there, you take the dirt from them, and they don't eat it anymore. A 6-year-old, 14-year-old, and a 30-year-old, no. You should not be eating, you shouldn't be eating small rocks. Like, okay, but then again, I don't like how they threw autism spectrum disorder in there because, and it kind of throws you when they throw that in there. That's like a distractor because they want to be like, well, do they not know that they shouldn't be doing that? It's a distractor still because it must be disappropriate for their age, which is what they're looking for. And the 16-month-old is what you would look for to lead you to your best answer. A 9-year-old boy is referred to therapy due to extreme pickiness with food, low weight for his age, and refusal to try new food. He avoids many textures in meals, often resulting in family arguments. He shows no fear of gaining weight and denies any body images concerns. What diagnosis is most appropriate? So let's go back and take a look. We've got some specifiers here that leads us to finding our best answer. Pickiness with food, that picky eater that I was talking about. Low weight for his age. He's refusing to try new foods. He also is avoiding textures in meals, and this also results in the family arguments. He shows no fear of gaining weight. Those are your specifiers. A says anorexia nervosa restricting type. It cannot be anorexia nervosa restricting type because The boy shows no fear of gaining weight. Anorexia nervosa comes with a fear of gaining weight. B says avoided restrictive food intake disorders. By now, we know that the answer is B, but let's take a look at the other ones because every question is an opportunity for us to learn. C says obsessive compulsive disorder. Nothing mentioned in the vignette lets me know that he has OCD because OCD comes with what? Compulsions, where it's repeatedly doing the same thing, thinking that that's helping with the anxiety, and it's not. It's actually just them feeding into the anxiety to help them comfort themselves. And that can come as much as what? Opening the doorknob over and over again, checking to see if you've locked the door, checking to see if you turned the stove off multiple times, washing your hands multiple times. That's more of your obsessive compulsive disorders. Binge eating disorder. With binge eating disorder, in the vignette, it does not explain that this boy is eating or consuming large quantities of meals within 2 hours of a time. So it cannot be D. It leads us back to B, which is the avoided restrictive food take disorder. Avoiding many textures, has low weight loss for his age, and he shows no fear of gaining weight, and he is also a picky eater. You are seeing a 2-year-old child in therapy for possible feeding difficulties. The parents say the child vomits several times a day and sometimes appears to deliberately bring food up. They say they discipline the child when it happens. What is your ethical obligation? Okay, this question here is kind of like, well, what is this question actually asking me? Like, they're talking about all this other stuff here, but then they're asking me about my ethical obligation. You have a 2-year-old child. He has feeding difficulties, and he's vomiting several times a day. Sometimes they are believing that he's purposely bringing the food back up. So ethically, what do I need to do with this client? Alrighty, so A says report suspected medical neglect to Child Protective Services. And I think here we are. This is one of these questions where it's like there are distractors in these answer responses. A is going to definitely be a distractor for me, but I'm going to keep reading the rest of them. B says refer to a medical provider for evaluation before continuing treatment. Okay, I like how that sounds. C says begin parent training on behavior management immediately. Now, C is also a distractor, but C is ignoring the fact that this kid has been vomiting several times a day. That's very excessive, and that's like a red flag that's going off. Something has to be going wrong. D says diagnose rumination disorder and begin systemic family therapy. We can say that it could be rumination disorder with given the little line that they said that he's deliberately bringing the food back up, but it doesn't says that the kid is eating it, rechewing and then eating it again. So D again is a distractor, and it's ignoring the fact that this kid has been vomiting several times a day. Something is wrong with that, and we need to look into that. Go back and let's take a look at A and B. A says report suspected medical neglect to Child Protective Services. The issue with A is we don't have enough information to even say it's suspected medical neglect. We don't have enough information to say that. We can't neglect it, turn it over to Child Protective Services. There's not enough information. But ethically, what we can do is we need to get this kid to see a doctor before you can even continue treatment, because the kid has been throwing up several times a day. That's excessive. Something could possibly be going wrong with him. We need to make sure that he's okay. It's always going to be safety first. The parents are probably, they don't know what's going on with him. They came to you for help. There's not enough information to say it's medical neglect. I believe if it could possibly be the answer of medical neglect if it must have stated something that, oh, the parents don't believe in the medication that the doctors gave them, and he's continuing to vomit several times a day. Now we got something that's going on. It's not up to us to decide, or even if it was something cultural where they're like, the parents they don't believe in medicine, but my kid is constantly throwing up several times a day. It's not us to decide whether or not if something, can go wrong with this or whatever. You've told me that you don't believe in practicing medicine, but yet you're bringing me your 2-year-old and he's throwing up every single day, and he's sick and something's wrong with it. I need to make sure that the kid is safe. CPS will then make that decision whether or not if they want to intervene. That's not my decision. But B is the best answer. Refer to a medical provider. I need to make sure that this kid is okay. I need to make sure he's safe. Safety first. Protect your clients. Protect your license. This ends the questions for the feeding disorders. I hope each and every one of you were able to learn, gain, and understand how to decipher between these questions and navigate these questions. If you have any questions, comments, or concerns, please don't be afraid to reach out to me and let me know. I will be around to support you.